Hello, everyone. Welcome to the Brown Surgery Podcast. I'm your host, Kenneth Lynch. For those of you that do not know me, I'm a PhD educator and nurse practitioner by training. The focus of this podcast is to span both clinical and educational fundamentals and turn everyday topics into interesting discussions that can benefit students, residents, and faculty alike. So I'm really excited about the topic of today's discussion because this kicks off a multi-segmented podcast covering a topic that is getting a lot of attention of late. When operating, it's definitely one thing to be in command of a case and telling your first assistant what you need from them. This is certainly one of the things we train surgical residents to do over the course of 5 years of residency. For residents in particular, it's an entirely different scenario when they have to take on their required teaching cases and get into the position of taking a junior resident through a case. How one gets trained on this is not something that is standardized amongst training programs, and there's a lot of discussion nationally on this topic. So, this process of moving from the role of intra-operative learner to intra-operative teacher is what we want to explore in this series of podcasts. To start us off, I would like to welcome two senior surgical faculty here at Brown. Dr. Christine Emmick and Dr. David Cloutier are both well known to our local listeners. Both are products of our surgical training program here at Brown. They both have busy clinical practices, and they both have a lot of insight with training residents in the operating room. Chris, Dave, welcome to the podcast. Jumping right into it, the first question I'd like to ask both of you was, what was your experience like transitioning from resident to attending?
Dave and I have a pretty similar background in that he and I both went right from residency to general surgery practice. And for me, I sort of felt ready, but I realized that there's definitely still a learning curve after you get out of residency. Back in the day when we didn't have the work hour restrictions, maybe we were a little bit more prepared. We had a little more autonomy and probably did more cases as residents, but you're still learning after you get out, which makes it a little bit difficult to be teaching at the same time. But I think both of our environments when we got out were very supportive. Like in my group, anybody who had a big case, we helped each other constantly. We assigned, another attending to each other's cases. And it wasn't just, help the junior kid. It was, if my partner, Dr. Healy, had a bypass, one of us was helping him, which was great because I was, had help with all my big cases, but also I got into the OR a lot with my senior partners and, just continued to learn. Mm-hmm. So, but I think the challenges of starting a practice is that you're trying to develop your own reputation. You're trying to develop a referral basis. Having your own patients for the first time is really, so much more responsibility than I think you can be prepared for as a resident. So there's a lot going into it. And I think it is a tough thing to be able to, at the same time, take junior residents through cases as well.
I think when you're young, you're a lot less willing to let them struggle through it for hours and hours. I find I used to take over cases a lot quicker, my first year or two, because, there are times that I was worried I would get through it, basically. As you get more experienced, I think, I find I let the residents struggle a little more now than I used to because I know I can bail them out now, or there's nothing they're going to do that's going to, burn any bridges and, make it so, you can't fix it a little bit later, basically. But it's very different, I think assisting someone else doing surgery is very different than when you do surgery. Like when I don't have a resident, now I feel lost. I was like, wow, I'm used to, spreading the snap and having them moving. Now I got to figure out, how to do it without residents or, like even if you have like places that don't have residents, I think you do surgery different, it's you with the Bovie, it's you doing it. You got to come up with different tricks. I find that I'm almost, I'm used to doing it with residents. I'm more comfortable doing it with residents. And when I'm all alone or with someone very experienced, like a scrub tech, it's just a different set of maneuvers for even, doing a hernia, basically. It's different. I realize the residents find that it is something that's different. That's kind of a skill set that you need to develop, basically. So.
Yeah, I like to stress to them how important it is also to, even if I take a case away from them, it's probably because it's a tougher case. And I think it's really important to learn how to be a good assistant. So, I get a little, I think it's upsetting if you have to take a case from a resident and they act dejected or upset about it. But, on the other hand, it's almost more important if you're in a tough case for them to be there as an assistant.
How do you balance that? I guess, when you balance like what you want them to get out of the case, but also, patient outcomes, obviously time in the OR, you got to move on
through your day and get the next patient into the OR in an hour or two. How do you facilitate that process?
It's challenging, definitely. I mean, I think as long as they're, making progress and you're heading in the right direction, it's okay to kind of to struggle a little bit. Or there are definitely times where, gallbladders in particular, it's funny, like I find if they're really struggling, I try to save them from the other side of the table. So it's that, when you go to the other side, you take it away from them, it's that, oh, I couldn't finish the case. So now it's fine. I almost try to do the surgery from the wrong side. Let me look for a sec, spread, and then everything becomes obvious, and then I let them kind of, finish the rest. And I find it's that physical, me kicking you out of your spot, you go in there. My goal, even if they can't do the case, I don't want them to leave the case saying, wow, I'm a moron, I couldn't do that, So it's a matter of, I think you got to try to make it feel like, even though they haven't, sometimes make it feel like they learned something, they did part of it successfully, not, wow, that didn't go well, I didn't do it, I'm afraid to go back to the operating room because I don't want to screw up again. For junior residents, feeling like a buffoon in the operating room is sometimes, it's counterproductive. They don't want to go to the operating room again because they're afraid they're not going to be able to do it. Then they feel bad about themselves. It's this vicious cycle where they want to stay out of the operating room. They're afraid to fail. They're afraid of like the negative outcome or confrontation. So I find more and more I try not to, quote unquote, take over the case completely or say, hey, let me try for a sec, without moving positions, without being in the obvious surgeon's position, try to like do it from the wrong side or, just try to make it.
And there's good and bad ways.
Yeah.
For sure to do that. I mean, you can be very encouraging and say, let me just try a little bit of this and then give the case right back to them and not be degrading or demeaning to the resident. So there's definitely good and bad ways to kind of, help out a little more than letting them do the whole thing. And I think laparoscopically, especially, that brings in a lot of other challenges. I think for me, sometimes I have a hard time teaching because I have a hard time really articulating verbally what I want them to do. And, you can't control them that well other than verbally. And sometimes you're turning around and pointing at the screen. But for me, doing more and more cases laparoscopically, that's been a challenge, is just kind of articulating well what I'd like them to try to do. And you also have less control over the case with the laparoscopic surgery. So it's a little bit more stressful. I find it really stressful when like a chief is trying to take an intern through an appy and I'm like, 2 people back, but you got to let them do it. And as long as with experience, if you learn, when to intervene or when something dangerous might be about to happen, then that's just part of teaching.
Yeah, I think both of you have mentioned it. Like, how has your approach changed taking an intern versus a chief through a case, or a 2 or a 3, like based on the level of the learner? How do you prep yourself and how do you prep them, I guess, for success?
I mean, I think you expect a different amount from each of them. The interns, don't know what to do on a hernia, but they know if I say sew A to B, they can sew A to B. So it's more. I don't let them pick what they're going to sew. I say sew this to this. So it's more, I kind of set them up so they will be successful. If you say, what are you going to sew the mesh to down there? Most of them aren't going to know. But if I point to it and say, do it, so it's more hernias are intern cases because technically they can do what we ask them to do, but they don't know what they're doing for another 2 or 3 years. I mean, I say, if I left the room, you wouldn't finish the surgery, for 2 or 3 more years, basically, which is kind of the truth. So I think, getting the technical skills down at a young level and then, knowing exactly what you're sewing, what you're doing the dissection as they mature, So I think there are different parts of each case for each level where, you got to show that you've done the next step to move on to the next step. I mean, if you ask the intern to, show me what you're going to do, it just doesn't happen unless they get the experience. So, I mean, I try not to set them up to fail, if you will, yes. There's definitely parts of each procedure they can kind of do on their own, do independently, and then, kind of lead them to water, if you will, on the other ones so that, the net effect is a success, but yet there's sometimes not the knowledge of exactly what they're going to do. So it's more of a technical success than knowing what I'm doing success, if you will. So just so they leave with a success, not, I didn't know what I was doing, I couldn't even do it right. I think I just don't want them to leave the operating room, feeling like they failed. I mean, there's nothing worse than that. You just set up this, they become worried. I find people are always worried about their technical skills. They think it takes years and years. Even the ones that are good are worried about their technical skills. Like they don't think they're good enough in the operating room, even when they are good enough. So it's that reinforcement. Leaving the surgery feeling successful, feeling like you did it right, you knew how to do it. It's, I think, important because it feeds for the next case. So you're not afraid to do it, afraid to go in, afraid to get challenged.
Yeah. Plus, I think, getting into a case, if it's going to be like if you're going to do a gallbladder with an intern, if you get in there and it's a mess, you just say, hey, this is not a good first gallbladder case. I'm going to do this. So you don't set them up for failure by giving them something that is beyond their skill level. But on the other hand, if you have a nice, straightforward gallbladder and you take the intern through their first gallbladder skin to skin, that's very rewarding for us. And I remember the first time I did a gallbladder, I remember the surgeon who took me through it. And I hope that they'll always remember that I was their first attending to let them do a gallbladder. So it's very rewarding to get through those cases. I think as the years go on, it's nice also to see their progression of skills. And I try to talk less and less. If I'm doing a case with an intern, I'm talking a lot every step of the way. But if I'm working with a senior resident, I try to keep my mouth shut and just let them do it without constant instruction.
Yeah, there's a big push, I think, nationally, the same as we do the operative timeout, to do this perioperative educational timeout for residents. As you guys are speaking about this, do you guys try to meet with the resident beforehand to discuss objectives for the case, or say, hey, you know what, you're an intern or you're a PGY3, I'm going to let you do this portion of the case and I'll do the rest? Do you think that is something that you do, or do you think that is something that would be helpful for people starting a case, just to kind of set expectations up front so people don't get, as you're saying, mad because, oh, Dr. Cloutier just took this case away from me or whatnot?
I think I try to, say, what do you think the severity of the case is? Like, this is going to be an awful gallbladder, get ready. So that if you're not successful, it's not a shock, because a lot of them don't know they don't know they had a cholecystostomy 2-3 months before they did this and this, because, our HPs aren't that helpful. So sometimes it's more providing the clinical background and kind of giving them an expectation of where you think you're going to be. You should sail through this, or, this is biliary dyskinesia, this is a good rookie case, or more like the complexity. I find I do more of the debriefing, you did this part good, you did this part good. And because the evaluations are just so vague. I find when I do an evaluation, it's, it's like everyone seems to get a C across the board, and it's hard to, unless you do a really, really good job, it doesn't break it down that much by the way I evaluate them, if you will. You did a good job with the cystic duct and cystic artery, but, it was a thin wall gallbladder, you got into the gallbladder 5 times, or more. What parts were great, what parts do you need to kind of work on, or what helped, what trick did you finally do, or what did I do that made things obvious, eventually. But I think it's a good point, certainly expectations up front is, I think it tends to let them know, what they should expect of themselves, so they're not shocked at the end when it gets taken away from them, or, this is going to be awful, I'll give you a shot, but let's see what happens,
Yeah.
I mean, I think it's more of the complexity expectation, I think, is useful.
Yeah, I feel like I could do better with that, and especially since these residents are working with so many different attendings, and everybody does everything differently. So in a lot of ways, it'd be helpful to say, okay, we're going to do this appendix. I use a harmonic scalpel and I use endo loops, and this is how we're going to do it. And just for them to kind of know what's coming, I think is helpful. But that debrief and pre-brief or whatever, I think would be really helpful. I should really try to do more of that. Yeah, I think, and also I like days where I'm working with one resident and we have 3 hernias, where it's a repetitive thing, which I think is really helpful for people to do the same case over and over again with the same person in a row. That doesn't happen very often, but I think that repetitive thing is good. And I think for me, if I've worked with a resident a bunch recently, that helps too. I let them do more and more each case. Sometimes I have an intern that I've never met before walking into a case, and I just don't know anything about them. So, it's definitely a little bit of a ramp up for level of responsibility in that manner as well.
Well, I think, what would your suggestions be, I guess, for residents who are starting to do teaching cases, whether they're at the VA or at the Miriam or here at Rhode Island, as they're taking a junior through a case? What are some tips you would give them to be successful in that role? Because it's, like you said, it's not easy kind of going to the other side of the table and being a good first assistant and help making sure that they're doing what they should be doing, but kind of giving them the tips to succeed at the same time.
I think I try to be cool. You want to take the residents through a case and let them do things, but you have to keep in mind the patient's best interest as well. So if it gets anywhere to the point where it's taking forever or something's getting dangerous or, you're not headed in the right direction, you just have to take the case and you can't feel bad about it. That's going to be the ultimate goal. And like I said, learning to be a good assistant in a tougher case like that is just as important as doing the case. So I think it's really your level of comfort and, just keep the patient safety in utmost priority.
I think when you're starting to teach, you almost have to do a little more of it than when you really know how to teach. So it's like when you kind of get a little bit stuck and the intern's not helping you, then even though you're technically the teaching assistant, I think you got to do a little bit of it. You got to kind of, do a little more. So it almost feels like you're doing the case and you're not taking them through the case. And you don't realize that you don't completely know how to take someone through a case till you try to, and I think, a lot of the time they struggle is, quite frankly, you've never done it completely by yourself from start to finish. We always take a little bit away. We do a little something, or, it takes 3 years before you realize that, you doing the bovie between someone's clamp is not you doing the surgery. The scrub tech can do that. You feel like you think you did the case because you held the bovie the entire time, but someone told you where to bovie. And then when you turn the tables and you're like, here's the snap, explore the cord, and then you realize you're like, wow, I guess I've only done this part a couple of times. Maybe I'm not quite ready to take them through this case, And I mean, for the chiefs, a hard hernia as a chief to take someone through will, stump them occasionally. I find they think because they're chief, they're ready to do it. And then that's what makes you realize, like, wow, I gotta do a few more of these completely on my own with an attending before I can take, someone through it. Just because you're chief doesn't mean, and it's case specific. Some chiefs can take gallbladders through cases, and some, hernias I find are arguably the hardest. The residents are pretty good at gallbladders eventually, but I tell the chiefs too, like when the mid levels, like 3s and 4s and 5s, will always be the surgeon on like a gallbladder. But I find you do the same moves you've always done since intern. When you watch someone else do a case, like an attending do a case, or a different attending, or a different resident, you almost like learn moves and maneuvers because, you haven't watched anyone do the surgery for a while. So you haven't learned anything new. And I think you get the next level of sophistication. I often tell them when you're a chief, just, take an attending through the case, go on the other side and set it up for them, doing the retraction, doing the stuff like that. Or, the people that are going to be fellows and doing general surgery call, that it definitely, you gotta, the assisting part is the hardest part half the time, on a hard gallbladder, how to show it to them or something. So.
When I first was starting out, I felt like the most stressful parts for me were like the simplest things. That, like as a chief, you're doing the big trauma cases and all the big cases. But then, I was, seeing patients in the office. That was something new for me. And, just knowing, what procedures I could do in the office or, what the next step in the workup was. That was almost one of the more stressful parts because that's just something we didn't do a lot. Endoscopy, I started out doing a lot of endoscopy, but anytime I was a resident, if something got hairy or the scope was redundant or twisting or whatever, somebody would quickly take it away from me. So, that was, those are things I had to work through on my own. And like some of the simpler cases that I hadn't done in a couple of years because I was a 4 and a 5, like hernias, those were the toughest things. So yeah, I would encourage people to, really try to envision what their practice is going to be like when they get out and maybe try to, take a day to go to Dr. Cloutier's office and just see what office hours are like, or, try to be an endoscopy more if you think you're going to do that and really try to be the one who's going to finish that procedure. So.
That's helpful. And I think both of you just kind of mentioned it too. Like, how do you promoting that autonomy, I guess, is what we're ultimately getting at. And is there a way to do that well Like, do you let them just kind of, how much do you let them struggle? If failure to progress is like a clear sign that we should like take the case over, but what strategy, I guess, do you use to continue to promote autonomy as you kind of work through a case with whether it's an intern, a 2, 3, or a chief? Because that's what they're all looking for is autonomy by chief year. Can we do a better job of that, I guess?
I think different residents show different initiative with trying to pursue autonomy in some ways. I feel like some of the chiefs you can tell that they take more initiative and they're just trying to, prep and drape the patient and really get things set up, where others are sort of standing back a little bit more. So part of it has to be on them, I think. And you can, as intending, I think you can sort of sense, which chiefs are striving for that more. And I think you tend to give them more. I think each attending has different comfort levels as far as how far, how much they'll let somebody struggle or how far they'll let a resident get towards danger. I really like digging out of danger. I like preventing danger, but other people might feel differently,
I appreciate both of you taking the time to go through this. I think it's really helpful to talk about because a lot of these questions that you just answered are the residents are asking every day, at least if not to other faculty internally. So I think this would be good to give them a little viewpoint into your world and what you think about daily as you're operating with residents and what they're ultimately going to have to deal with as they move along their career continuum. So I appreciate it.
I feel like it's different now. Like I said, I think when we trained, we had more cases, more autonomy. I think now, there's such a big trend for people to do fellowships, mainly because maybe they're not quite ready at the end of residency to.
The literature says, yes, they go into it because a lot of them, not only for career goals, but because they need to catch up. But it also says at the end of a year or two that they are confident now and they feel like they can go into independent practice. And I think it's important. It's probably a reflection of the 80-hour work week to some extent. But yeah, I think it's tough. But our goal is to, promote autonomy in the best way we can.
I think especially now, COVID has definitely cut down on their cases. A lot of the mid-levels and chiefs are just really feeling like they're already behind the 8 ball, even more for those several months that, they weren't doing surgery, and it's hard. It takes a while to get that confidence back that, you're going to be okay. I mean, I think in our program, we do enough surgery that most people are pretty confident when they finish, whether or not they realize it. That's the next step. Everyone's got a different, comfort level, how many times they need to do things before they can, want to do it independently or confident about it. But it's challenging right now. It's a tough time.
You must be doing a pretty good job because everybody comes back.
Yeah.
Yep.
Cool. Well, I think this was great. I think the residents are going to get a lot out of this.
Great.
All right. Thanks, Ken.
All right. Thank you.
I'd like to say thank you to everyone for listening to this podcast. Please be sure to check us out next week, where we will continue this discussion with some of our junior faculty here at Brown, namely Drs. Andrew Lurs and Marco Andrea Giorgi. They're both going to give us their perspective on what it was like transitioning from residents and fellows just a couple of years ago, and how they promote operative teaching and resident autonomy while balancing their own goals as junior attendings. So stay tuned for that, and we will see you in the next episode.